Good evening, everyone, and good morning to Dr. Adrian. First of all, I would like to thank the Inform Forum for giving me this opportunity to interact with you all on this important topic. So today, let's get going. I will be discussing about blood flow volume measurements in AV fistula. And we know that blood flow volume measurement is one of the complementary method or for AV fistula surveillance, in addition to the clinical examination and the information which we get from the parameters during dialysis. And the two common methods which are used for this volume flow measurements are ultrasound dilution method and the Doppler, which we can use for blood flow volume measurements. So to accurately do this blood flow volume measurement, we need to have some idea about the Doppler technology and the basic principles of Doppler. And then we will discuss about the procedure, actual procedure steps of volumetric analysis and a short video demonstration of the procedure. So, you know that Doppler is basically detects the relative motion between the source of the signal and the reflector of the signal. In our case, source of the signal is basically the trans. So basically Doppler detects the relative motion between the source of the signal and reflector of the signal. So in our case, source of the signal is the ultrasound transducer probe, which transmits a frequency generally taken as transmitted frequency, and this frequency is reflected by the red blood cells in the blood vessel, and this reflected or frequency is again received by the same ultrasound probe, and it is called received frequency. And when the frequency is reflected, it is changed by the red blood cells, and the change in the frequency is basically detected as Doppler shift or Doppler signal. And depending on how much there is change in this frequency, the machine tries to calculate whether there is movement or not, and what is the direction of the movement, or what is the frequency of the movement. So there are generally commonly three types of Dopplers which are used, being the color Doppler, the spectral Doppler, and the power Doppler. In volumetric analysis, we basically use the spectral Doppler and the color Doppler. So this slide shows the typical picture of the color Doppler of a kidney, and you can see we can select a large screen area, and this helps in identifying whether there is any flow or not, and it also gives us idea about the direction of the flow and the velocity of the flow. In the upper picture, you can see in the right corner there is a color map which has been enlarged in the picture down, and in this color map, the color which is on the upper side is taken as a standard, that it will represent the flow towards the transducer, and the color which is present on the lower side will represent the flow away from the transducer. On this color map, we can also adjust the scale. Like in this, it is representing up to plus 40 centimeter per second of velocity and minus 40 centimeter per second of velocity. And also we can see that as the flow increases, the color also changes. It becomes more brighter. In the upper case, it will become like a bright yellow, and if it's moving away from the transducer, it will become like greenish color. So which will give us an idea about the direction of the flow and some idea about the velocity of the flow as per the scale we have chosen. In volumetric analysis, we then use spectral Doppler. Spectral Doppler is basically we are interrogating a small area of the blood vessel, and it gives us more accurate idea about the flow velocities, flow direction, and a wave pattern. All the blood vessels in their normal physiological state and pathological state, most of them have this typical waveforms, and just looking at the waveforms, we can know whether the AV fistula is working normally or there is some problem with it, especially the low flow, or there is any turbulence. So the duplex interrogation of AV fistula helps in easy evaluation of hemodialysis access, because the arteries and veins are superficial, and so they can be easily evaluated on the ultrasound, and along with the B mode, they can help us in identifying and localization of the abnormalities and interrogate these abnormalities both structurally and functional. Information is provided by the analysis. Most commonly used probe for this is the linear probe, which has a 5 to 12 megahertz of frequency. The ultrasound probe has a marker which helps us to align it with the screen on the ultrasound, and before starting the case, we should first take the proper alignment of the probe with the ultrasound screen. So next, when we actually go and measure the blood flow, we have to first identify a good place, good site to do the AV fistula flow measurement, and then we'll have to adjust the various parameters like angle of insonation, sample volume, correct the aliasing if it is there, and accurately measure the inner diameter of the vessel. And we'll go through one by one through these. So our ideal site for blood flow volume measurement will be the one which is easy to focus, has non-tapering uniform diameter, has a straight segment, has a laminar or a plug flow, acute insonation angle can be achieved, and has a stable diameter which is not changing with the cardiac cycle or with the respiratory cycle. So we have to understand that the values which we get from this Doppler study will only be correct and good if these technical parameters are actually met by the procedure. So there is actually no perfect site for measuring blood flow volume measurement, but nowadays brachial artery is commonly used for AV fistula flow measurements, both for proximal and distal AV fistulas. And the site commonly chosen is few centimeters proximal to anastomosis, because it is believed to be, that it will be having more laminar flow. Arteries are not easily compressible, so the shape doesn't changes with the probe pressure, and you can have easier insonation angle as it is deeper in location. But problems with the brachial artery can be that one thing is that it can overestimate the blood flow, because the flow which is going distal to the fistula will also be included in the brachial artery flow measurement, and there can be significant variation in the diameter of the artery during systole and diastole. So that can affect the blood flow measurement. So the other place which can be used is the vein, the outflow. Generally, at a distance of 10 centimeters or further from the anastomosis is chosen, believing that the turbulent flow, which is generally found near the anastomosis, would have changed into a laminar flow at a distance of approximately 10 centimeters. But we'll have to choose a place which doesn't have tributaries, aneurysms, or dilatations or stenosis for correct volume flow measurement. So this will actually show the real flow in the fistula. But problem with the veins is that they are easily compressible with the probe. They are very superficial, and getting a good acute angle of insonation is very difficult in the veins sometimes. And if there are early tributaries in the initial part of the vein, then again the measurement will not be correct. So the important thing being the angle of insonation. So angle of insonation is the angle formed by the ultrasound beam and the blood flow. So this angle is the angle of insonation. Why is it important? It is important because the Doppler frequency, the changes which the ultrasound actually picks, the Doppler shift, is directly proportional to the cosine of this angle. So any change in this angle will actually affect the Doppler shift. And as we can see in the this slide, if the ultrasound beams are at 90 degree to the blood flow, then this angle is 90 degree, and cosine of 90 degree is 0. So ultrasound will not actually pick any Doppler shift, and it won't be able to measure the velocities and blood flow. As the angle becomes more acute, the ultrasound beams are much better in picking up the changes in Doppler shift, and a degree of 60 degree or less of acute angle is required for correct measurement of these parameters. And in this also, we'll have to remember that while doing, even if you choose the angle of 60 degree and then you choose the angle of 40 degree, there will be some difference in the volumetric analysis. So in my experience, I think we should stick to one angle. For most of my studies, I will stick with the angle of 60 degree to keep the consistency. If the blood flow is vessel is very parallel to the skin and we are not able to get acute angle of insonation, what you can do is you can tilt your ultrasound probe using a lot of gel so as to create an acute angle. But we'll have to be careful, because in case of veins, this even a little bit of pressure will actually compress the veins and change the shape of the veins, its diameter, and that will change all the readings. So next we'll need to understand about the sample volume. So in a blood vessel, in peripheral vessels, we know that the blood doesn't flow with the equal velocity throughout the vessel. The velocity is more in the center of the blood vessel, and it is lower on the near the walls of the vessel. But we need to measure the mean of all these velocities so that we can accurately estimate the blood flow through this area. So during blood flow volume measurement, we keep our sample gate wide, covering almost complete blood vessel. While in case when we are evaluating for, say, stenosis, we try to keep these sample volumes small so that we can correctly pick up the peak systolic velocity or the acceleration time, and it is not affected by the other velocities, and there are less artifacts while doing this study. Also, our fistulas can have very high flows, so we can have a problem of aliasing. So in this vessel, we can see that we are seeing bright yellow and red color flow in between, which is showing that flow is towards the transducer probe, high velocity flow. But at the same time, we are also seeing islands of bluish color, which signifies that the blood flow is in the opposite direction. So this is very confusing. And this is happening because we have chosen the inappropriate scale. So the frequency with which the machine is interrogating it, this velocity is probably less and is unable to pick up the accurate changes. In most of the ultrasound machines, the scale is directly related to the PRF, that is pulse repetitive frequency. That is the frequency with which the Doppler machine is actually interrogating is this area. So if the flow is very high and Doppler is slowly interrogating this area, it will misread this velocity. So here in this figure in the middle one, we can see the wave represents the flow velocity and the arrows represent the frequency with which machine is interrogating at this area. And depending on this interrogation, it is making its own waveform, which is actually doesn't matches with the what is actually happening in the body. So in this case also, we can see aliasing. We can see the scale here, it is kept at 10 centimeter per second. When the same scale is increased to say 40, we can see that aliasing has disappeared and you can see a uniform color. Similarly, in the spectral Doppler analysis also, you can see that there is aliasing. The peak is very high and the machine is not capturing it properly. The peaks are coming in the bottom of the part. And when you bring the baseline down, or you can increase the scale, and you will see that the waveforms are now properly visible. We have to adjust this scale as per the velocity area which we are interrogating, so that the waveform forms around 3/4 of the scale. The other things which are available on ultrasound machines to make our life easier is that instead of sending the beams at 90-degree, beams can be sent at an angle of say 20 to 25 degrees, so that you can actually achieve this acute angle of insonation to make things easier. Also, we'll have to arrange the flow direction indicator. This white line in between the sample gate is the flow direction indicator, which indicates the flow in the blood vessel, and it should be aligned parallel to the vessel wall to get correct estimation. So correct diameter measurement is also essential, because the blood flow volume measurement will be a square of whatever diameter we choose. So whatever mistake we do, it is going to get squared. So two ways of doing it are, whether one is that you take the measurement in short axis, inner diameter needs to be taken. If there is a lot of variation during the systole and diastole, you can take the diameters in the M mode, and here you can take the diameter whenever there is minimum variation. So actual procedure steps being that both you and the patient should be in comfortable position to carry out the examination, because the stability of hand is very important. And if you are doing a detailed examination of the fistula, it's going to take some time. If you are doing only the blood flow measurement, I think it's going to take only 5 minutes or so. So initially, I prefer to do a B mode and color exam of the complete circuit, and then try to find out what is going on and find a good site for blood flow volume measurement. Then we need to focus the vessel in the short axis and then rotate the probe by say 90-degree to bring the longitude direction in focus. Then choose a correct sample gate, align the flow indicator parallel to the vessel. Have to see that the angle of insonation is correct, 60-degree or less. And then I think the rest of the measurements are mostly done by the machine itself. Measurement should be done on an average of 3 to 5 cycles. So blood flow volume will be actually mean velocity, which we will be calculating into the area, which will be pi r square, because the cross section is a circle. So area of a circle is pi r square. Then the velocity is in centimeter per second. To calculate the flow in ml per minute, we'll have to multiply it with 60. So that we can get flow of for a minute. I prefer to do it at least 3 to 4 measurements and try to see the average. So this is one of the video. So this patient is having a proximal fistula where we put a saphenous vein graft from brachial artery to mid-arm cephalic vein. And this is a young guy, and we can just have a look at it. So this is the brachial artery. This is the brachial vein along with the artery. This is in the longitude direction. So we're trying to focus the brachial artery. Now, this is the spectral Doppler, which has been now put on. You can see this is the brachial artery. This is the flow direction, which is parallel to this vessel wall, sample gate, which are quite wide. And here you can see the angle of insonation, which is shown by the machine, calculated by the machine, is 60 degrees. So you can see the scale. So it's a high velocity fistula. So baseline has been brought down to prevent the aliasing, and the scale is up to 350 centimeter per second, and flow is coming somewhere around, say, 250. So once you freeze the image, then there are auto calculation, and the machine is trying to find its flow. So the peak systolic velocity has come as 273. Mean velocity is around 140. And now once you enter the diameter, it will calculate the blood flow volume to flow rate. So diameter is around 5.5 millimeters, and the flow at this place is coming around 1950 ml per minute. So which is a high flow area. Similarly, this is showing the same measurement in a radial artery. It can also be done in a radial artery, but it will many times underestimate the flow, because we know the flow in a radiocephalic fistula also comes from the ulnar artery through the palmar arch, backflow. So I'm just trying to focus the radial artery. Sometimes it can take some time. So this is the radial artery. This is just a color image. And then we are going to put the Doppler in it. Adjust the sample gate to encompass the whole artery. Again, the angle of insonation is around 60 degrees. And just measure the diameter. So flow in this radial artery is coming around 400 ml per minute. So take home message, I would say, is that accurate blood flow volume estimation is feasible, but it is technically demanding, and it's operator dependent. Even small errors in measuring the blood flow volume can result in large variation in the actually volumetric analysis. There is a lot of inter-operator variability. So I think if you are doing, you should do it yourself and then do the serial measurements, which are more useful, and do it. And when you are recording this in the patient file, we have to record where exactly you have done this measurement, and you need to keep it doing at the same place again and again to be meaningful. And it is a good way as a complementary to other evaluation which we do for AV fistulas. So thank you. I will be more than happy to take any questions if there are any questions.
Thank you. Thank you, Dr. Ajay.